Can I introduce our last speaker for this session, Dr. Kay Knight. Dr. Kay Knight is a seasoned rural health educator who calls herself the accidental researcher. I'm interested to know more. Kate today is presenting her presentation is on using a systems perspective to redefine the role of the rural clinician. Welcome.
Thanks. So for anyone who was in the session just beforehand, I have no headpieces. It's okay, don't panic. And if you weren't in the session, you just missed out. The reason I call myself an accidental researcher is because I found a topic that I didn't mean to research, it just no one else did. And so it just happened to be. So what happened in 1999 was I was asked to be involved in some training of some rural nurses in the Western region around telephone triage, because the the West Vic Division of General Practice was just launching their telephone triage service as part of one of the projects for nationwide looking at reducing workloads for GPs. And one of the first things you do when you go to prepare an education program is A, go and find the literature, and B, find out what everyone else has done beforehand. And what I discovered very quickly was that there was no literature around this particular area. And so I waited for 5 years for everyone else to do something, and they didn't. So I ended up doing a PhD simply because no one else was coming up with an answer. And what happened as part of my research was I actually ended up redefining the role of the rural nurse. And if we look at that role, and thanks very much, Tim, for starting off this process, and also Kate, is that the rural nurses are defined as an expert generalist, and the role is often looked at around the health characteristics and behaviours of rural people, and also the scope of practice that's required to meet that, and the challenges of providing a rural health service. So, as I said, I didn't plan to redefine the role. I started off, the study was actually looking at what actions nurses take when people telephone small rural health services with unscheduled healthcare needs. And I'm going so small that we're talking about unfunded urgent bay, no doctors on site, 1 RN, aged care, a couple of acute care beds, and as Tim pointed out, people just see the sign hospital and think it's the Alfred, and so they just turn up with everything and anything. And often they ring first or they call, and there was no literature around what it was that rural nurses did. But what was very interesting was we were running study days around how to deal with these phone calls, and we'd have nurses coming to study days that were called telephone triage, and they're saying, but we don't do that, because there was this unwritten ground rule, or these policies that said you can't diagnose over the phone, you can't treat over the phone, and there was a lot of myth around all of that. And as I said, I waited 5 years for someone else to come up with it, and they didn't. So I ended up a study that was a case study that was used Yin's methodology, and it was 3 phases. So I looked at policy that was national government policy, grey literature, professional policy, and also hospital policy, as well as interviewing directors of nursing and also rural nurses. So I had 8 small rural health services, 8 directors of nursing, and 15 RNs, which is not a lot, but I can tell you now, a lot of people didn't want to talk to me because apparently they didn't do it, but everyone rang the hospital, so it was a hidden practice. So what I found, skip another 6 years, and I did the thematic analysis on the data that I got, and the interesting thing is that I found exactly the same as what everyone else has found when they've done rural research. But what was really missing in it all was the interplay. There was this complex interplay that was going on between these factors that I couldn't quite fully understand. And it's where I actually went to realistic explanation, which was work by Pawson and Tilley, and it's getting 1997, so it's getting fairly long in the tooth now. But the idea is it was one of the earlier sort of systems thinking's approach, but it was accidental because I didn't go into it thinking it was a systems thinking approach. I discovered when we got the theme for the conference going, my God, that was a systems thinking approach. That'd be great for the presentation, wow. But what Pawson and Tilley do with realistic evaluation is they look at what works for whom in what circumstances when something is introduced. But this wasn't a program. What I was looking for was exploring and describing a practice of what was going on. And they use realistic explanation, which is what might happen for whom in what circumstances. So it explains the status quo, what's happening right now. So one of the limitations of realistic evaluation is, unfortunately, even though they're dealing with the complexities of a system, they try to put it into lists. They use these configurations. And that was a real problem because you ended up with all of these really long lists, and there was the relationships and the interplay wasn't coming together. And I'd been using framework analysis, so I thought I'll put it in a matrix and see what I can do. And I actually played with the mechanisms and all of that sort of stuff and ended up with another, equation. And all that really means was I came up with what might happen for whom in an uncertain circumstance, because there was just no you couldn't fix things. So what did I find? I found rural nurses recognise the competing needs and multiple perspectives of people involved in care. So that included the community, but also protecting the GP. A lot of their work was around dealing with and meeting the needs of people who are isolated and lonely, who rang the hospital with just needing to get some sort of connection and some care. They added this workload to their existing clinical workload, and it was unrecognised and unfunded. They had a felt need where they needed to meet the expectations of that community, and that was part of their role. The difficulty is, of course, they're working in an environment where there's limited resources and not many options, and so they really had to broker a best outcome, because while they were trying to meet the needs for the community for care, they're trying to protect the GP from actually doing too much work after hours, that sort of stuff. They gave the people options for care, and that always included presenting locally as well, to come in and see us. It was done in a highly orchestrated way. They used assessment. It wasn't just off the cuff. It wasn't Nana advice or anything like that. It was orchestrated, and again, it was trying to balance a best outcome. They had a bag of tricks and tools which is really based on their experience and knowledge, not only of the health behaviours but of the community and understanding the local needs. It required logistical thinking as they try to, again, find that best outcome amongst all these multiple possibilities and perspectives. And they did it alone, because they were usually just one RN working with other junior staff. There was no doctor, they had no one to draw upon, and they had to make the decision by themselves. What was really interesting, though, is there was a lot of worry that, what do they say over the phone? And what I found was that they were very conservative and risk adverse in the options that they provided. And there was no boundary crossing at all. That they did not cross into the GP's professional practices or anything like that. They stayed very firmly within the boundary of a nurse. They did this all in a context of policy being misaligned with practice. So what happened was the policies often said, don't give advice over the phone, don't, provide any, don't answer the phone, that sort of stuff, but they all did. And what the administrators did was they knew that the policy didn't fit practice, but what they did was just pretended that they weren't doing it, because then we wouldn't have to admit it. And that meant that they spent most of their time with their head in the sand, the administrators that is, and because they denied it and there was organisational defences, it just became the undiscussable, and then the undiscussable became undiscussable. So what does this mean? What I found was it wasn't about the scope of practice, but it was about the context. By accidentally using a systems type thinking approach, I was able to really look at the ambiguity around the context. And what it told us was that rural nurses had high levels of tolerance for ambiguity. And there's another group that have that, and that's successful global corporate entrepreneurs. And so I took a theory from that by Lane and Klenk, which looked at the components or elements that made global corporate entrepreneurs successful and applied that to rural nursing. And so what it gave us was this idea that they were ambiguity masters, and it started to look at the contextual complexity and the cognitive affective capabilities and characteristics that's required to manage these uncertainties in rural health. That's the model that's been published, but it gives us some questions around what to think about looking at expert generalists to ambiguity masters, because it doesn't just relate to nurses, it relates to all rural clinicians and raises new questions about preparation, support, recruitment, retention strategies, the role of the community in moulding a service, and also who's making the rules and are they helping us or hindering us. Thank you.